One of the things that we're lacking right now is a head-to-head trial comparing acalabrutinib versus ibrutinib. We know the individual study data, Illuminate, Elevate, Resonate. We know all the information, and we can, kind of pull out and tweak, okay, this is better than this, but we truly need a head-to-head trial looking at ibrutinib compared to acalabrutinib. Again, ibrutinib has been used for years. Patients have responded very well. Unfortunately, again, we have the side effect issue, but none of us can say for certain that one is better than the other without looking at them directly compared to each other. So I think that we need to do that because when you think about a competition, you're going to have half the physicians saying this one's better and half the physicians saying this one's better. And I think to really prove that, we're going to need some scientific evidence. Knowing all the information we do now, knowing the side effect profile of ibrutinib, knowing the side effect profile of acalabrutinib, knowing the efficacy of acalabrutinib specifically, I would use it first line. I wouldn't hesitate, and I have not hesitated to use it first line monotherapy. Again, going back to Elevate, when you're looking at the data of acalabrutinib monotherapy, again, not compared to, but individually looking at the data with acalabrutinib, plus obinutuzumab for a patient who's a little bit older, and I don't want to add possibly increased risk of bone marrow suppression with obinutuzumab, I probably will use a Calquence or acalabrutinib alone, and I have. In fact, I've started 4 new patients on acalabrutinib for CLL in the last 3 weeks, and I have not started the obinutuzumab with it just because I know the data and I don't feel it's necessary right now. Doesn't mean I won't add it later. So for me, and even looking at the NCCN guidelines, forget my opinion, it's there, first line. Whether you have, a 17p deletion, you are without the 17p deletion, it's front line, acalabrutinib plus or minus obinutuzumab. And so for me personally, I would use it first line in any situation. High risk cytogenetics, age greater than 65, it really doesn't matter. I think the drug has proved its worth, and I think that people are doing really well. We get asked, well, if there's a patient who's intolerant of ibrutinib, would you consider switching to acalabrutinib? And the answer is yes. It has been shown that a substantial amount of patients, I think close to 70% of patients who have side effects warranting discontinuation of ibrutinib, when they switch to acalabrutinib, side effects go away. Additionally, 13% of the patients that still experience side effects when they're switched to acalabrutinib, they're grade 1. They're very tolerable. The patients can take the acalabrutinib without any issue. So to think that one BTKI, one and done, that's not true at all, and that patients do fare quite well when switched from a first generation such as ibrutinib to acalabrutinib.